Again, I'm just very honored to be here and be talking with you and learning from you today. My name is Jenny Halpern. I'm an orthopedic oncologist at Vanderbilt, and I'm part of really a consortium of surgeons that feel very strongly about caring for TGCT in a way that meets our patients' needs. And with that, it's vital to us to learn from you all, and that's why I just excited to get questions from you and hopefully give some direction as you look to find pathways forward. This is our team. All of us are going to be, I think 3 of the 4 of us will be on the panel today. But this is the orthopedic oncology group at Vanderbilt. Dan Johnson, who's here in the audience, is on your left. Josh Lorenz, who's the director of our division, is next. And then me. And then our senior mentor and teacher is Dr. Herb Schwartz. And Dr. Schwartz started the Vanderbilt program almost 40 years ago. And the primary point he always made in teaching us was that you have to make a diagnosis, because everything that you do moving forward will depend upon that diagnosis, and it will tell you the right way to proceed. And I should have mentioned Dr. Cox. Dr. Cox is one of our sports surgeons at Vanderbilt. I believe he's maybe on the panel this afternoon as well, but he's also a vital member of our team. So again, going off of that lesson of Dr. Schwartz, the big question for us in orthopedic oncology is always, what is it? And obviously in this case, it's TGCT, but we're going to come back to that too. I feel like Britney Spears now.
I'm so sorry.
No. I do like some karaoke. I think Kevin knows that, but I will try to abstain. It's pretty bad when I do it. So when we think about a surgical perspective, honestly, the most important part of that perspective is, how do we think about a problem? And thinking about a problem is not just having a hammer and using it on a nail, which is the legend of orthopedics, if you will. Like we can do a lot of things that may not necessarily be the right thing, but how are we going to think about this, and how are we going to figure out the best way forward in a complex situation? So today I kind of want to talk about, what is it, that important question. Why do you hurt when you have it? How do we make a diagnosis? And then what we can use from a surgical standpoint to make things better. The realities of those surgical interventions based on really the limited information out there. And then finally, what's it all about? What does it mean to you, to the patient who is living the experience? And so the what is it question is really interesting with TGCT, because in 1852, there was a case of a nodular density on a flexor tendon in the hand. And as they began to describe this thing, they noted that when you removed it, it came back, and that it had erosive qualities. It could cause damage in bones. And because of that aggressive behavior, they actually thought it was a malignancy. A malignancy is a tumor that can spread. And so with that, with thinking it was a malignancy, some of the treatments that were used included things like amputation with the goal of eradicating tumor. As you know, that is not appropriate for what this disease is. And in 1941, it was described more as an inflammatory, benign process. But I think the biggest discovery, really from a simplistic way of looking at this, that was most informative was in 2006. And that's because they identified that this is a clonal process or a clonal abnormality, and therefore a neoplasm. When we talk about a neoplasm or a tumor, we're talking, though, about a benign tumor. And the specific abnormality that rendered this process possible was a translocation, which resulted in the overexpression of CSF1. And I know a lot of you know a lot more about this, honestly, than I do. And so sometimes I just like to talk about the things that I know you know, but to make sure that we're all on the same page as we go forward. The second thing is that when they looked at the cells that express this abnormality, the cells, the neoplastic cells, are actually in the minority. So a majority of the cells don't have the translocation, but that doesn't matter, because that minority of cells that has it creates a landscape, an environment, a milieu where an inappropriate inflammatory process is ignited. And so with that, because of the translocation and the overexpression of CSF1, you get a firestorm. You get a firestorm of inappropriate inflammation. And so this is an old person's attempt at animation to understand what's actually happening. My younger and very amazing partners would have things flying in, and it wouldn't look like Elmo on a bad drug trip. But this is how I like to think about it. Again, a minority population has the ability to incite, transform, and change the behavior of the cells around it. And with that, macrophages are recruited, and massive numbers of inflammatory cells essentially make up this heavy tumor process in your knee. And that was my attempt to show the active, it's pretty bad, but I am hoping it illustrates the point. So that being said, knowing that we have a clonal process, a neoplasm, and then understanding the mechanism behind it, it really helps to do one important thing, and that's to answer the question, what is it? We take care of a lot of patients with sarcoma, and part of the problem of studying patients with sarcoma is that there's no common genetic core initiating process. There's no origin story that you can really identify. All of those tumors are very variable, and while TGCT is very variable, understanding the molecular or cellular activities that happen to make it possible really allows us to begin to understand what's happening at the gross level. And so now we can name something. You can name it because you know what it is and you know why it's caused. And as that name has evolved, whether it was PVNS or now TGCT, what we do know is that this is a locally aggressive but benign tumor. When it happens in the joint, it's based in the synovium. When it happens outside of the joint, it's usually associated with the tendon sheath. And these are some gross pictures of what we can see. When I say gross, I do have gross pictures. Thankfully, Dr. Stern helped me to eliminate some of them. But I think it's important, not to, this will sound cliche, but to kind of see the enemy and understand what you're dealing with and what it looks like. And it is often stained this brilliant orange color. And that's because when you get such bad irritation of the synovial lining, you often have bleeding into your joint. Many of you have probably had an aspiration of blood or fluid, and it's bloody. But what happens over time is that the synovium gets stained this bright, radiant orange color. And we also know that there's different variants of TGCT, and those variants impact surgical decision-making. Those variants, as you know, are nodular disease and diffuse disease. So on the top images that you see here, one of them shows you an arthroscopic panel of what a nodular focus of TGCT looks like, and the correlating MRI scan. And on the bottom, you see another arthroscopic picture, and this more represents diffuse disease. I like to think it looks like coral or algae, but it's all these inflamed orange fronds of diseased synovium. And when this happens, it can happen outside of a joint. It can happen inside of a joint. And as you know, the predominant location where it happens is typically the knee, but we also see it in the hip, ankle, wrist, shoulder, elbow, and even TMJ or spine joints. So I think this is a really important basic question, but why do you hurt when you have it? And why you hurt is because all of that inflammation, that massive inappropriate recruitment, results in uncontrolled swelling. That swelling causes pain, and we'll talk a little bit about why that is. That swelling causes stiffness, along with the fact that many patients have already had a synovectomy, which renders them less able to produce normal joint fluid. And then finally, this disease can get so bad with such a rabid inflammatory reaction that you actually get gross destruction of the joint, osseous erosion, cartilage destruction. And so there are many reasons to hurt. I think all of the patients that I've seen with symptomatic TGCT have an effusion or swelling on your knee. And then we'll talk a little bit about a vicious cycle that these inflammatory responses evoke. So this is the way I like to think about a joint. This is the knee joint or the hip joint at the bottom, but most joints are surrounded by a capsule, and that's kind of like a balloon. And that capsule is lined with normal synovial cells. And those cells can be macrophage type or fibroblast type, but their job is to create a healthy, lubricated joint that works well. I like to sometimes draw an analogy to how arthritis causes some of the similar feelings or findings that you have in TGCT. And how that happens is that if you have an injury in the knee that evokes an inflammatory response, the synovial cells are put into overdrive, creating an excess of fluid. That fluid distends that balloon capsule, and that actual distension itself is very, very painful. And in addition, the distension of the capsule can cause things like palpable cysts. It can also cause a decrease in range of motion. If you've ever noticed you can't straighten your knee all the way out or you can't pull it all the way back and bend it, it's because of the distension of the capsule from fluid. And so what happens in TGCT is that instead of there being an injury which evokes that inflammatory response, the actual clonal disease cells ignite a false fire alarm and recruit all of these inflammatory cells to not only evoke an inflammatory response, swelling, but to also create mass lesions. And those mass lesions or collections, like we saw in the prior photos, they can put actual erosive bodies or foreign bodies in the joint that then dig into the bone. And so the end stage of TGCT in a joint is typically bony erosion, joint destruction. With all that, I was just talking to Dr. Stern, and again, the most important thing is to make a diagnosis. And in trying to learn about the patient experience with TGCT, it seems like many patients are misdiagnosed for even years, and they don't understand, like, how can I hurt so much if I go to the doctor and they tell me I'm fine? Because that can be the most frustrating feeling. Like, I'm not okay, but I am not crazy. Why are you not making a diagnosis? And so when we think about that, making a diagnosis, the first and most important thing that we do is listen. If you listen to someone who describes what you have gone through, then often that's the way for us to see where are we going and what is the problem. In terms of a physical exam, patients have swelling, decreased range of motion, even clicking or popping or mechanical symptoms. And then imaging can also help. X-rays, MRI. We often can say that TGCT will cause changes on both sides of a joint. So if there's an erosion on both sides of the joint, we tend to think of a benign process as opposed to, let's say, a malignancy. Biopsy is crucial if there's a question, and we'll talk about that a little bit more. And then to consider what treatment option best serves the patient. And I think that's the nuance of this disease, is there's not one right way to proceed. If you're asymptomatic with PVNS, maybe you don't treat it, right? So it's really trying to figure out on a case-by-case basis what's the best way forward. These are some of the examples of X-ray findings that we'll see. So I apologize. I'm going to try to use this pointer laser thing, but like here and here on both sides of the knee joint, you'll see these large erosions. And I think that we tend to see more erosions in the hip joint. So you can see on the top part of the femoral neck, there's the ball of the ball and socket joint, and the bottom part, you'll see these erosions. And I think that the capsule around the hip joint is inevitably much tighter and closer than it is in the knee joint. And as such, as you develop solid disease in that joint, I think the erosions that we see tend to be more profound. This is an example of an MRI scan. You'll usually see an effusion, which this is an image where the bright stuff is fluid, but you'll also see that in the bright stuff, there's all this dark stuff. Some of that is synovial proliferation. There's also something called a blooming artifact, which is back here. And that's just that when you get recurrent bleeding into your knee, there's iron in blood. The iron gets deposited in the synovium. And when the iron goes into an MRI scan, there's a type of susceptibility that makes it look bigger than it is, and it makes that area look dark. And that's called the blooming artifact of PVNS or TGCT. So there isn't always a reason to biopsy, but biopsy is critical. It's the gold standard of making a diagnosis. If we don't know the diagnosis as an orthopedic oncologist, we biopsy, whether it's for this disease or any disease that we see, because you need to know the answer. Typically, if you are biopsying, it's done prior to resection. But if someone is going to the operating room and they open the knee or go in and there's any concern, it's very important to consider intraoperative biopsy if there's any questions. And that's why one of the reasons why we like to do these cases at a tertiary care center, where we have the luxury of, like Dr. Singh, who you met earlier, to be able to look at tissue in real time while a patient is still under anesthesia. There are a limited number of tumors that grow in the joint or arise from tendons, but some of the things that we consider are synovial chondromatosis, another type of synovial proliferation, ganglion cysts, which are benign, not cancer, basically sacs of fluid that can be in the bone, a synovitis or synovial sarcoma. A lot of people talk about synovial sarcoma. Synovial sarcoma is named because the actual cancer cells look like synovial cells, and it can or has a tendency to occur in and around a joint. And that's why we always think about it when thinking about any articular process. But typically the differential is pretty small. This is what it looks like grossly. This is one of Dr. Schwartz's photos. And again, you can see that orange color, that thick, shaggy carpet. And so when we meet a patient and we feel like we have a diagnosis, then we talk about treatment options. And again, those options have all been presented today, I believe. Observation with monitoring in asymptomatic patients, excision, which is what we'll expound on a little bit here, and obviously medications. We tend to use medications when we don't think that surgery can render a disease cure. I think the most important thing that we do at Vanderbilt is have a group of people that we have a lot of faith in discussing patients on a case-by-case basis. I put a bad picture of silos up, but I love the silo reference. I don't know anything about farming, and these may not even be farming silos, but they do reflect this idea. As medicine has gotten more and more advanced, what's been lost is an ability to have knowledge about someone else's specialty. So you'll meet people and they're the experts on X, but they don't know anything else. And I think patients see that more than anyone, because you go to a doctor, they think you have a problem. That doctor doesn't know what it is, but they also don't know who to send you to. You can end up going to doctor after doctor after doctor. So what Tumor Board does for us is we have in one, it used to be room, now it's a Zoom space as time has gone on, but we have people from all disciplines, and many of that you've met today, that allow us to understand what may work best on a case-by-case basis for a solitary patient. And so surgery, and Dr. Stern again tried to help me here. I had some gross photos, because usually at a surgery meeting, people are like, yeah, but I think we removed everything bad. I am so sorry if there's something in here that is disturbing. If you want to see more invasive photos, we have those also. But surgery is sort of simple. That's what they say at Tumor Board about us too. But the role of surgery is to remove what's abnormal. And in this disease, if you can remove what is instigating the inflammation, you can see how that would render a potential cure. And so for us, it's important to understand anatomy and approaches. And I think really at the end of the day, the expectations. So we use a variety of words. And so this is really just a vocabulary slide. In joints, we talk about arthroscopy, arthrotomy, and arthroplasty, all the A's. We'll go into each of one of those. And for tendons, we often talk just about debridement, removing it off of the tendon. The goals of surgery in localized disease are to remove the whole tumor. Again, Dr. Stern was just showing me a patient who's unfortunately had an intralesional resection that resulted in a profound and overt recurrence. And so when we see a nodule of PVNS, we like to remove that nodule en bloc. In diffuse disease, it can be helpful to decrease symptoms by debulking, but our surgical goals and how we translate that to expectations for the patients change, because we likely will not render a patient cured with surgical intervention. And so this is probably my most important slide and the most important message for today. I don't think there's a magical surgical bullet, if you will, to take care of the problem. And there are variants of the disease that surgery works better for. But I think that as a surgeon, while we have one tool that can help, the physical and mental burden of this disease is unique. You know, when you have cancer, we talk about a cure or an endpoint. When you talk about a benign entity that causes physical difficulty without a clear, I'll be done with this in 3 years, there's an aspect of dealing with the physical part, like Kevin talked about, but there's also the aspect of like, when am I going to be better? And living with that thought. And so I think that's the hardest thing. And I think that as surgeons, our group tries to be very sensitive to the fact that we want to help, but it's not perfect. And that we validate your journey through all of this. So knee arthroscopy is the one where we make small holes. And that has some advantages. Through small holes, they're about 5 to 7 millimeters long. We can insert a camera. When I say we, this is definitely our sports medicine colleagues, because orthopedic oncologists just do a lot of more big incisions. But we can insert a camera and we can address or attack disease in all parts of the knee. Typically, that's associated with a faster recovery. I will say that there is a misnomer. You know, if you have a knee scope that you get a total synovectomy with, you're going to be stiff and it's going to hurt and your knee's going to bleed. And I think it's important to understand that even through a small incision, you can do a big surgery. Some of the disadvantages of arthroscopy are that some PVNS, as you know, can be extra articular, and that you obviously can't address through the scope. These are examples, again, of just arthroscopic pictures. Knee arthrotomy is the concept of making a large incision through which we can see. And this is the orthopedic oncologist's role in surgical care. The advantage is you can really access the whole joint, although there's some nuances or subtleties with that. You can access tumor outside the joint too. We do arthrotomies from the front. That's an anterior arthrotomy. That's a lot like a total knee replacement incision. We do arthrotomies from the back. On the back of your knee, if you feel the skin there, compared to the skin on the front of your knee, you'll notice it's really thin. And so we worry a lot about wound issues on the back of your knee. And so one problem we have is after we do a posterior arthrotomy, we want to put you in a knee immobilizer so that the skin could heal. But if we put you in a knee immobilizer and we're not moving you, that's a problem too. Now, posterior arthrotomies, in addition to the skin healing, you can also develop something called a fistula, which is a connection between the joint capsule and the synovium and the skin. And we've had patients with draining fistulas from the joint itself. For the hip, same thing. We can do open approaches, anterior, posterior. We can get there a lot of ways. We can also use arthroscopy to address hip disease. Typically, we have been doing some more arthrotomies in the hip versus the knee, but either way, the approaches are somewhat the same in terms of conceptualizing them. When PVNS or TGCT gets to the end, what it causes in the joint is a destruction of cartilage surfaces. It causes pain, it causes erosion, joint space narrowing. And in that setting, joint replacement is indicated. We can talk a lot about joint replacement. I know that the panel would love to talk about joint replacement. My partners are also arthroplasty surgeons and have a benign arthroplasty practice. But we're going to talk a little bit about arthroplasty at the end too, in that when I was learning 25 years ago about managing this disease, the goal that we were taught was that you were trying to treat it to save the joint, to prevent joint replacement. But at the end of the day, if a patient needed a joint replacement, you know, okay, no problem. At that time, the parts didn't last as long. They weren't as good. And that's why we were avoiding those surgeries in younger patients. But the reality of arthroplasty in patients with TGCT is a little bit different, and we'll come back to that. So we do have some research that helps us guide our clinical practice. Number one, as you know, the rate of recurrence in nodular versus diffuse disease is different. In nodular disease, there's a 9 to 15% recurrence. In diffuse disease, that's 50 to 70%. With localized TGCTs, you can again see the 3 to 10-year recurrence rates are pretty good. Some of the factors that may matter are if there is a nodular focus that's greater than 5 centimeters, that has a greater risk. Oh, sorry. Yes, that's correct. So sorry about that. And I'm sorry, I can't see, like, I have to make a judgment on these things, so I apologize. Thank you, Sydney. The factors that matter in recurrence rates include size or if you've had a prior recurrence. Again, diffuse TGCT has a darker recurrence rate or recurrence-free survival in that we are less good at preventing recurrence in diffuse disease. I crossed this one out, but I can show that one later. I didn't know what to do. So 20 years ago, we were learning from a surgeon standpoint what to do with this disease. We often thought that, well, we could let someone scope from the front and we'll open the back because our arthroscopy colleagues couldn't really get to the back of the knee. But that's really changed. Dr. Cox, who we work with a lot at Vanderbilt, he can get anywhere in the knee and he makes all these portals where he feels comfortable and confident navigating around the back of the knee. The back of the knee is where your popliteal artery and vein are, where your tibial nerve or peroneal nerve are. But he, like many other good arthroscopists, feel comfortable with that. Arthroscopy is less operative time, less blood loss, decreased length of stay in the hospital. And now, as of 2014, which is actually a long time ago, but the recurrence rates are near equivalent. So we're getting better with arthroscopic management of diffuse disease. But I did want to again point out that with the hammer and the nail thing, not every arthroscopist is the best doctor to treat this disease. So you have to have a thoughtful case-by-case assessment of a patient because you don't want a patient who has a small nodular disease and an arthroscopist going in and putting a shaver on and just shaving it and seeding the joint to create a worse problem when there was something or a problem that could have been managed. So arthroplasty. So again, I thought that it was the cure, but it's not necessarily. And why is that? Well, the rates of complications in total hip arthroplasty in patients with TGCT is much higher than the average patient who gets a hip replacement. In addition, there's some unique findings. This primary aseptic loosening, what that means is when you put a hip replacement in, you either put it in with a glue like cement, or you press fit it where you put a stem in that's so tightly in a canal that it stays there and has some ingrowth or on-growth surfaces that keep it steady. But in TGCT patients, there is inherently a higher incidence of loosening. And I think that's because your inflammatory status of your joint is so much different than an average patient. And so in arthroplasty, even if you don't have aseptic loosening, patients are prone to be stiff. They can have recurrence of their disease around the implant. It's not perfect. And I think why I think this meeting matters so much to us is that, we've had the opportunity to meet your advocacy group. And I think what is important in rare diseases is that people come together that can share their own experiences and have a passion for creating a pathway forward. So this is, Dr. Stern kindly let me use this. This is from a presentation that will be upcoming. But what she has noted is that patients that have a hip replacement in the setting of TGCT, they don't get the type of pain relief or functional improvement that other people should get if they had a hip replacement. And as she wrote, this underscores the need for figuring out how to manage this before we get to the arthroplasty stage, because in fact, I don't think that arthroplasty is necessarily the cure or the end game for TGCT. There's too much else that has gone on with it. And so this is just a patient case that I think illustrates the root of the problem. So this patient actually presented to Vanderbilt in August of 2022, but prior to that, in August of 2019, he had had an arthroscopic synovectomy. He had recurrence with repeat arthroscopy. Then he came to us in August of 22 with swelling, pain, decreased range of motion, and he had this arthroscopy, which if you look in the top two panels, shows you that hemosiderin stained active synovium. So he then developed arthrofibrosis, not necessarily a recurrence, but his knee was stiff. He had to have another arthroscopy. And then in 2025, he did pretty well, but in 2025, he noted new stiffness, new symptoms. He was discussed at our tumor board and he was prescribed or started on a medical track. he did get some relief from that, but noticed significant side effects, nausea, fatigue, and progression. And so he was discussed again at tumor board, and he went back for yet another arthroscopy. And again, this is the new surgery. You can see the recurrence of disease at that time. And so this patient is 27 years old. He's had 5 surgeries. He's had a medication, essentially failure, where he had recurrence and side effects. And I think it highlights the where do we go from here question. And so I think that our hope, as from the surgical standpoint, is that we do have ways of impacting variants of this disease that are truly helpful. But part of that impact depends on knowing who will benefit from it and who will not, and how to create a multidisciplinary platform in which you can get the best treatment possible. And I'm excited to be able to answer questions on the panel with my colleagues here, but I think it's really important that our patients talk too, because I think they have probably the best perspective of the actual experience. And so I'm really happy to turn the platform over to one of our loveliest of patients. But I did just want to say thank you very much for your time and attention.